Great. Well, thanks very much, Stephen. Appreciate the introduction and the opportunity to speak. Again, I think the plan for our session between Christine and myself is just to give you some overview of, what the demand was, how we responded to the demand for increasing capacity, and what we learned from our own experience over the past 7 or 8 months. Again, a big thank you to Christine, who truly spearheaded and really did an outstanding job in preparing our lab, in ensuring we met all the requirements and moving it forward. I don't know we could have gotten to where we are today without Christine's guidance and dedication. So thanks very much. So let's start. I think the 3 objectives for this afternoon. One is just show the changes in testing criteria and government policy, how they can quickly affect the demand for testing. Certainly the Ontario or the provincial government put out a number of different guidelines, which they updated periodically, changing who could or could not be tested. And you'll see what happens when they change the criteria, the number of people that come forth wanting to be tested. Look at how our lab went from, the capacity of in mid-March from about a few hundred samples or tests per day to where we plan to be by first week in November, somewhere over 17,500 tests per day. And again, it's important to recognize that I'm talking about test capacity. Whether we actually receive that many samples is obviously a different question, but it does raise an issue in planning when you're trying to scale up to meet a potential demand, yet you aren't quite there. What do you do with all the people, the equipment, the supplies, when you're still sitting around waiting to get that many specimens to come through the door? And then finally, look at what impact the MGI-BGI-960 has had. We have ordered 2 7000s. They're due here sometime in early November. So hopefully that will further help automate and streamline our workflow and processes. Again, because this is a presentation from a disclosure perspective, myself, I do have a number of relationships with a number of commercial interest companies, from grants to speakers bureaus, consulting fees, etc. And Christine, again, is much more pure than I am. She has nothing to declare as far as disclosures. And there's no potential conflict of interest here. Neither Christine or I have received any funding support from MGI or BGI. As I said, we're really here just to share our own personal experience of what's happened to us over the past 7 or 8 months. Okay, I think Stephen obviously showed you the map of Canada. And when you zoom up into Ontario, as he mentioned, Ontario has probably about a 40% of the population in Canada lives in Ontario. Having said that, most of the population is closer to the border along the north shore of Lake Ontario, Lake Erie, closer to the US-Canada border. And I've circled in the bottom right the Toronto, where we are. Understanding Toronto is now the 4th largest city by population in North America. We have a population just under 6.2 million people if you take the greater metro area. So a few years ago, we surpassed Chicago and are just behind Los Angeles, New York, and Mexico City. The only reason that becomes important is because that's where most of the patients are located. That's where most travelers coming into Canada will first stop before they move on to their next destination if they're not remaining here. And so there's lots of movement within the city, as well as a very large population of quite diverse individuals. This picture is just, again, meant to show you the institutions we serve as what we call our home base or our home hospitals. On the left, Sinai Health System is made up of Mount Sinai Hospital, which is the image at the top, and Bridgepoint Hospital, which is the one at the bottom. Just as a bit of trivia for you, the Bridgepoint site, the older part of that building, not the big glass piece you see on the left-hand side, used to be a high containment criminal jail system. In fact, if you go to this hospital now, on the first floor, they've kept the remnants of what the jail looked like. You can go into one of the cells, sit there and think about what it would have been like if you were a bad person. I'm not sure patients find that so interesting or comforting to know that they could be thrown in jail, but they've done a nice job in integrating that. On the right-hand side, sorry, are the University Health Network hospitals, and I show 4 of them here. In the top, in the bottom right-hand corner is the flagship Toronto General Hospital, which is the largest. Toronto Western just above it, and I think you can see our signature building in the background. The big, tall, skinny thing is the CN Tower, which for many years was the tallest freestanding building or structure in the world. And then on the bottom left is the Princess Margaret Cancer Hospital, and above that is the Toronto Rehab Institute. And all of these 5 or 6 hospitals are within about a 3 to 4 mile radius of each other. Mount Sinai, as is University Health Network, we're both large academic teaching hospitals. Mount Sinai has 442 beds. When you take into account we have a 40-bed neonatal intensive care unit. Otherwise, we are strictly an adult hospital. We do have a COVID assessment center, which opened up in early April. It's open 5 days a week, but only 4 hours a day. Whereas University Health Network has almost 1,300 beds and a COVID assessment center that's open 7 days a week from 8 a.m. to 8 p.m. So with that as sort of background, this slide here is a little bit dated. It's my son when he was about 3 years old. He's now 15 and 6'1". Unfortunately, my dog has passed away, so times change. And if you look in the bottom corner there, I'm the one left playing with the zebra, the giraffes, and the hippopotamus. But this is not how you collect a COVID swab. I was trying to teach my son how to be an ENT surgeon and get a good close look at people's tonsils. Okay, from, as I mentioned before, the first thing to look at is the government policy, which dictates who should or shouldn't be tested. So although we began our testing in March 11th, offering it, the government published on April 8th of this year recommendations or guidelines as to who should be tested. And clearly, hospital inpatients, residents living in long-term care or retirement homes, healthcare workers, caregivers, first responders, those in remote or isolated rural and indigenous communities. And the priorities, if there was limited resources, was really focused on people with symptoms, whether you were a healthcare worker, a resident, et cetera. The initial guidelines or recommendation was to test only those who had some symptom or sign that was compatible with possible COVID. Okay, now it's not moving. And when you look at the bottom right-hand corner of the slide, you notice that at the very end of the document, the government put a reminder saying that testing of asymptomatic patients, residents, or staff is generally not recommended. So the idea was only those with symptoms, only those that are sick at higher risk, but those who are well, even if you were a contact, generally it was recommended you don't get tested. About 5 weeks later, in mid-May, the government then added a few categories. Now it said that any Ontarian with only one symptom, so all you needed was fever, bit of a cough, some shortness of breath, etc., you would now qualify no matter what. And they added a category for asymptomatic patients, oncology patients, those receiving radiation treatment, transplant patients, and dialysis patients. And the bottom was really meant for people who were coming in and out of the hospital system, obviously to get their hemodialysis or their transplant or radiation treatment. And the concern was, yes, they could be asymptomatic, but they're entering an institution with vulnerable patients and therefore could potentially spread to them. So they opened up this asymptomatic category. And then about 9 days later, you can see they wrote in big letters, effective immediately. Testing is available for the following populations. And now symptomatic testing was for all people with at least one symptom. Asymptomatic people, which was risk-based, meaning anybody in the community who had a contact, who thought they might have COVID. And in fact, the overriding statement from that guideline release on 24th of May was that no Ontarian who is symptomatic or who is concerned with having been exposed to COVID will be declined to test. Essentially saying everybody and anybody who wants to get tested, you know, from the worried well to the truly sick, could just show up at an assessment center, no appointment needed, and a swab would be taken. So with that, of course, the number of centers we began to service increased dramatically across the province as we scaled up. And I'll turn this slide over to Christine, maybe to just describe how we did that and the number of different sites that now refer samples to us for testing in the lab.
Sure, happy to. Thank you, Tony. So when we started with the pandemic in early March, we were really just serving our hospital community, and to Tony's point around mostly things being about symptomatic patients, we found that initially it was serving the emergency departments and any acute patients within the hospitals. And you can see now with the percentages in the chart, that's really a very, very tiny share of who we serve. So when Sinai had started to build a bit of a reputation for being to respond really quickly, we were both boasting a very good turnaround time. Lots of centers from the surrounding area outside of the downtown Toronto core that we typically serve started to reach out to see where Sinai could help, because they're wanting to serve their communities better and didn't have the capacity on board at their local testing center to take on the volume. And so the COVID assessment centers started to crop up across the province, initially concentrated in the metropolitan areas, and we started to receive increasing amounts of volume. And I think we started in those early months, we had maybe 5 assessment centers, including the 3 from our own catchment area. And then very quickly, as the guidance started to relax and everybody was starting to overwhelm the assessment centers, we grew up to now serving 21 sites. And that is literally border to border in Ontario, well and truly past the assessment centers catchment that we used to serve. And then, of course, in May, we were starting to see some outbreaks within our long-term care facilities, the long-term care homes, with maybe more scantily staffed IPAC teams were starting to rely on hospitals for support. And so our hospitals were also assigned long-term care homes to oversee. And so we started to have some incremental volume from that area as well. I mean, at the time of making this slide, it was about 2% of our volume, but that volume does ebb and flow depending on the state of any outbreaks going on in the communities. And then there's another category that we serve, which would be research and any industry, any private services that people are trying to procure, and that has been a relatively static amount of volume. But I would say even as far as 3 weeks ago, almost 100% of our volume was coming from the assessment centers, and so happily that has settled back down to about 73 to 75 where we expected it to be, and that of course will ebb and flow with the way the policy guidance changes as well.
Well, thanks very much for that, Christine. So with that sort of, and as the number of centers referring samples to us, this slide just shows the number of tests we perform per month. So in March, we ended up, again, starting March 11th, doing just about 8,400 samples per month. Very quickly in April, that almost went up by about 4.5 times to just under 40,000. By May, we were at 67 and so on. And in September, we surpassed 150,000 tests per month, averaging about 5,000 to 6,000 tests per day for COVID. Now, in order to do that, of course, we needed equipment, we needed reagents, we needed people. And so when you look at where we started at baseline in March, you know, we went around our own laboratory and said, well, what equipment do we have currently in the lab that we could perhaps capitalize on without having to buy new equipment, get contracts, et cetera, procurement, and so on. So we had a C-gene instrument, an Altona instrument, an AltoStar as it's called, and 4 Luminex Aries towers. And so that's what we started with. We contacted those vendors, tried to set up supplies, reagents, kits, etc., get the instruments programmed. And we had about a capacity, if you look on the right-hand side, of about 1,100 tests per day. Clearly, as we saw the demand go up, we then moved to purchase 3 additional C-gene instruments by early to mid-April. And that now increased our capacity to about 3,000 tests per day, but still not enough, hard to keep up to demand that was coming through the door. By end of April, early May is when we got the 3 BGI, MGI instruments, and now we had a dramatic increase in our potential capacity from 3,000 to 9,000. Now, the nice thing about getting the BGI, MGI instruments was it was a good bargain for us. You buy one, get 2 free. So although we purchased one was funded by a donor to the hospital, and one was founded by the Firefly Foundation in China. So that was a nice sort of bonus to us, not having to purchase 3 pieces of equipment, but rather getting 3 for the price of 1. Still, as the summer sort of began and we moved into June, it was clear still not enough. And we then went back and looked at what other pieces of equipment we had in the lab. And we did have a Roche Cobas 6800. We had tried earlier to work with Roche, but because of limited supplies, plasticware, reagents, we couldn't do it. But finally, by June, they were willing to give us a small allotment of reagents, and that increased our capacity to just over 10,000 tests per day. I think at the peak throughout this, we probably got about just over 8,000 in a single day as far as number of tests we put through. Again, this graph here just shows you those kind of numbers, contrast it to 2019, the sort of same 6-month period from April to September. Obviously in 2019, the blue bars were without COVID. So that was our background sort of testing volume. Remember, we are a general microbiology lab. We do bacteriology, virology, mycology, molecular testing, etc. And normally we range somewhere about 50,000 specimens or tests per month over that 6-month period, and that's those blue bars. When COVID hit during that time, 2020, from April to September, you can now see those sort of reddish brown bars where a continual rise in the number of tests we were receiving, almost exclusively increase in COVID. There was some decrease in the number of tests we received for other things, bacteriology, et cetera, as the hospitals went into somewhat of a lockdown, eliminating elective surgery, outpatient procedures, clinic visits, et cetera. But again, the difference between the green bar, which was purely COVID tests during 2020, and the brown red bars, the total number of tests, that difference is the remaining other specimen types we were doing. So clearly when we reached over 185,000 a day, about 150,000 of those were now COVID tests. With that, of course, we saw an interesting phenomenon. And one way you can check when you're increasing your capacity is, you want to ensure that the quality of the testing you're doing it on multiple different platforms, and you're trying to figure out, are they all working equally well? Well, one way to do that, of course, is one could track different QI indicators. And one of them we track, of course, every day is our positivity rate. And so the blue bars represent the number of tests per month from March till the beginning of October. And then the dashed line represents the positivity rate. Now understand that positivity rate may be influenced by many different factors. One is, of course, the activity of the disease in the community you serve. So initially, from March to April, it was going up. Our positivity peaked somewhere around 12% of the tests we were doing were positive. And then gradually through the spring and into the summer, it began to decrease. So one could look at that and say, well, okay, that's fine. You did the public health people, all the social distancing, et cetera, was working, and the disease activity went down. The second possibility, of course, is the patient population is changing. And that is to say that, as we were doing outpatient, initially just symptomatic people, as you add in the asymptomatic, it dilutes out your positivity rate. And certainly that may have been a contributing factor. And third, one can look at this and then say, from a lab perspective, how can I use this to see whether in fact what we're doing is reasonably accurate, given that we're using so many different platforms? And one of the ways you can do that is to ask the question, am I getting a similar positivity rate on each platform? Or is there one that's giving me a very low positivity, another one very high, given that samples are being placed on these instruments at a very random process, so they're not being skewed towards one population or another. And I'll show you that in fact, the equivalency of the positivity rate, regardless of the platform, suggested that they were all at least functioning reasonably well. Clearly, in late August, September, October now, we're starting to see that positivity rate rise, and approaching now roughly 4% of the samples we're doing are positive for COVID. So with that, again, we come back to that big jump in capacity. When we added the BGI, MGI, we added 3 analyzers. We cleared out a space of approximately 680 square feet. I measured this myself with my footsteps, and had some power lines dropped in for feeding the instruments, 220 volt power. We had a class 2 biological safety cabinet there for some of the initial processing. We placed in a incubator capable of holding the samples at 65 degrees so we could inactivate them. We don't add Triton, we don't add any other substance for inactivation. It's 65 degrees for 15 minutes. There was already bench space there. We needed storage space, and we've co-opted a number of areas around the hospital to do that. And we had to have 6 Bio-Rad CFX96 thermal cyclers. Since each BGI instrument can put through approximately 2 microteter or 96 well plates at a time within about an 80-minute time frame, we then needed the thermal cycler in order to actually do the PCR reaction and read the plates. So we have 2 thermal cyclers for every BGI instrument in the lab. And just to show you, this is our BGI room. The top left-hand side, you can see 3 techs doing the initial processing of samples at the bench side. From there, if you swing over to the right-hand side, the smiling girl with the face shield is Catherine. She's happy because the 3 machines are ready to go and she's got nothing to do waiting for the other 3 techs to feed her plates. And then at the bottom, everybody disappears and you see now the green light, which makes me happy because it means all 3 BGIs are running. They all have 2 plates or 2 96 wells, microtiter plates on them, and we should be expecting just under 600 samples to come out in a few hours. So clearly this was the sort of workflow we had set up in our own lab in this relatively tight space. Obviously, before we could test the samples, we have to receive the samples. And so again, tribute to Christine, who was able to co-op the classroom about 25 yards down away from the lab, remove everything and set up what she has affectionately called the hive. So I'll turn that over to her to explain how we transformed the 14th floor classroom into our data accessioning area.
Sure. The hive is absolutely my baby. So when we realized how quickly we were going to have to scale and how soon we would need to revolutionize how we accessioned the work, the first thing that presented itself at Sinai was that we did not have anywhere near the footprint to be able to tackle that kind of manual input. And so for all of the work coming in within our downtown core catchment area, most of that is interfaced. And so it really is something as easy as receiving the bag with the nasopharyngeal swab in it. It's been barcoded, and we just need to scan it into our system as received and move it on to aliquoting and then subsequently testing. But when you take on as much work as we do from outside partners, from all of those assessment centers across Ontario, that is still a very manual process where the sample arrives with a paper requisition, and all of that has to be manually transcribed into our system. And that is wholly reliant on people. And so not having enough seats in our lab proper, we had to find some space. And so I went on bended knee and was able to get a classroom redesignated as microbiology space. And we looked at what the target the target work that needed to be done every day was, and what the province was expecting of us, and then went back and did a bunch of productivity calculations on the folks that were already doing data entry in the lab space, and realized that a typical data enterer can process about 300 requisitions a day. And so we created a hive, not just to meet at that point, the 10,000 a day target, but to really plan for a potential doubling. And so what this room can do is actually, if it's fully staffed, there are 18 workstations in total there. If it's fully staffed 24 hours a day, we can achieve 20,000 accessions based on an almost 50-50 interface versus paper split. And we continue to work with our customers all the time to try to find some sort of electronic connectivity to make sure that the order can come in electronically, and then the result can conversely go back out electronically. But I do believe that we're always going to have a paper piece. And so this hive concept has been working out well. And we've had lots of folks come in to observe what the workflow looks like, how we ensure proper patient identification, and make sure that everyone stays safe in the process, because this isn't typically designated lab space. And so all of the samples in this area are still closed. There's no sample manipulation, nothing like that. It really is just a matter of keying in information and barcoding, but still managing all of the PPE just in case there happened to be any type of exposure. And so we were able to construct this area. I mean, it's not pretty. I'm the first one to say that, but it absolutely does the job. We were able to put this in place in under 2 weeks when we got our call to action to be in a position to offer 10,000 tests a day. So as Tony said, we were already there as far as bringing in all of the equipment and capping it off with the BGI equipment. But what we needed was this front end workhorse in place. And so the hive was affectionately created.
And then finally, this slide is just to show you what happens to the specimens after they've been aliquoted, accessioned, tested, and now are ready for either discard or storage. And this is, you can see that each rack has a date on it and indicates when those samples were arrived in the lab and when they were tested. But what I think you should also notice is the diverse number of sample types. You can see there's red caps, yellow caps, pink caps, blue, white, etc. And this creates a problem for us because every single media is different. Therefore, every single media or tube type has to be validated with every single assay we do. And so since we were offering 5 different assays, from the BGI to the C-gene to the COBAS, etc., we had to validate all of these sample media transport types with each assay. And at one point in circulation, there was 21 different media types for which people were using to collect nasopharyngeal swabs. So it created a huge headache in terms of validation, verification, but also in terms of storage. We wanted, because we're an academic center and there's demand for some of these samples, which are precious, particularly the positives for research. We had an outbreak in one of our hospital wards, not here, but at the Toronto Western, where they asked that the positives be pulled and genotyped and so on. So we decided we'd save all positives. And initially we were quite ambitious. We were going to save about 25% of the negatives. Then we dropped it to 10% of the negatives. And now all the negatives get thrown out just because we don't have any more freezer space or storage space. But I think it does give you a visual picture of the complexity of what can happen very quickly when you start receiving samples from multiple different sites across such a broad geographic area. Okay, so looking more specifically now at how did these assays performed. And so again, this is just some of our own data. I've listed in this table the 5 platforms or assays we use. And the first column is the limit of detection, copies per ml. And you can see here they're all reasonably close, except for the Altona, which is maybe a log higher, running about 1,600 to 3,000 copies. But the BGI, MGI down around 105 to 300 copies per mil, equivalent to the Roche, equivalent to the C-gene. When you looked at reproducibility, whether it was intra-run or inter-run, all of the assays seem to perform fairly well with around less than a 5% coefficient of variation, except perhaps the inter-run with the Altona. And then throughput, as I show on the second to last column, clearly the 3 BGI MGIs at 2,000 per instrument per day was what we calculated as our maximum throughput. With 3 of them gives us 6,000. So miles ahead, we need 3 C genes to achieve what we could get through a single BGI. We also did cross-reactivity studies with the different assays and platforms, and bought some commercial human coronaviruses, contained NL63, 229E, OC43, and the MERS-CoV, and there was no cross-reactivity. All the assays appeared to be highly specific for SARS-CoV-2. So this comes back, this slide, to what I mentioned before in terms of positivity rate. And here I only put the 2 big guys, the C gene and the BGI, MGI, and looked at August and September. And so when you look at August, we did about 27,000 tests using the C gene, and close to 3 times that on the BGI, MGI at almost 80,000. But when you look at the positivity rate, about 1.1 and 1.4 respectively, statistically no difference, suggesting that truly one is not more superior, more sensitive, or less sensitive for that matter. When we moved into September, again, we increased slightly our throughput on C-gene, but look at now the BGI, MGI, over 110,000 samples in that month were performed on the 3 instruments we had. As I showed you, clearly the positivity rate has gone up on both instruments, but again, statistically the same. So we felt comfortable that the assays were performing approximately equal. And that was despite the fact that we were getting a lot of pushback because the BGI, MGI detects a single gene, the ORF or open reading frame 1AB gene, whereas the target genes for C-gene are 3, the envelope, the RNA-dependent RNase polymerase, and the nucleocapsid or N gene. And people were saying, well, single gene may be a false positive, but in essence, the numbers look essentially identical. For those not familiar, this little cartoon diagram along the top just shows you the genome sequence of the SARS-CoV-2. And then the arrows just show you at different points, different countries who develop different assays, where their primer sets, et cetera, are targeted to. In Germany, they targeted ORF1AB, the E gene and N gene. China started out with the ORF1AB and then added the N and so on. Second from the bottom is the USA, which started with the Corman primers from the CDC and was targeting the N gene exclusively. So clearly the different assays target different areas, but at least in our hands, we felt comfortable that despite that, their performance was equivalent. Again, just some other things. I think Stephen went through this. You can do, 96 samples in 60 minutes for the RNA extraction PCR reaction. If you put 2 plates on the MGISP-960, you can do 192 samples in 80 minutes. They're compatible with multiple different thermocyclers. As I said, we use Bio-Rad CFXs. Takes about 1 hour and 25 minutes on the thermocycler for a total of probably around 4 hours start to finish from sample initial accessioning to final answer. Interestingly, the BGI, MGI were good to help us program our instruments to see whether we could combine them with other assays. So we tried BGI extraction with the C gene PCR, worked perfectly fine. We tried the BGI extraction with the Luminex X-Tag respiratory virus panel, which is comboed with COVID and worked perfectly fine. So at least the instruments are flexible that you can do these sort of combinations in order to further mitigate the issue with supplies and reagents. Turnaround time is always a quality indicator for all labs. You can see throughout this period, we've tried to maintain a target of under 24 hours. And I think for the most part, I mean, remembering this is an average turnaround time, there was some time in late September where things got quite hectic and we had a significant backlog where we went above that. But for the most part, we've been able to meet that 24-hour turnaround time, at least in the lab. In order to do all of this, of course, you need people, not just equipment, not just reagents, not just space. And again, I'll turn it over to Christine to talk about recruitment and human resources.
Okay, so recruitment throughout this pandemic has been exceedingly challenging. We did have the luxury at the beginning. I think earlier we spoke about the hospital locking down somewhat and not being as reliant on the microbiology lab for the typical throughput of work. And so in the early months of pandemic response, we were able to optimize the team that existed in the lab. And really, we had a little bit of help from folks being redeployed because maybe their own units had shut down, that type of thing. But for the most part, we could manage it internally. And then you'll notice sometime around June, the hospital started to open again. And so a lot of the redeploy support we were receiving in the lab went back to their home units, and the microbiology, the Bac-T, virology, and mycology side needed to be restaffed to 100%. And so then we needed to go out and find more people. And lab professionals in Ontario and across Canada are considered a very scarce skill. And so recruiting the cycle takes about a month to find some good candidates. And so we had our scale up plan to the tail end of June and into July, and we did have a good resource plan associated with that. But since then, in getting to our new target of 17.4 a day, it's been very, very difficult to recruit because all of the other labs in Ontario are also recruiting, and we're really vying for the same candidates now. And we're trying not to poach each other's staff and just be good partners in the entire response. So you can see the drastic increase of people that have had to come on in September and October. And it's great because we've got the need met with people. And they're really hard to get. So I'm particularly proud of my human resources team in being able to beat the bushes and get enough folks to come out and fill the lab. But as I said earlier, we haven't had an increase in a lab footprint. So to take a space that typically housed 55 people or so, and to now move it up to house just over 130 people on a routine basis, that's really challenging. And so to maintain social distancing and to ensure that employees are kept safe has been something that's been a bit of a moving issue for us. And so I think it's important to highlight that, because if anybody in the micro lab goes down because of a potential exposure or illness, it means that the micro lab is going to be in a fair amount of jeopardy. So we're always focusing on that. If you can get people, great, but we need to keep them safe and productive in the meantime.
Okay. Just quickly in the last couple of slides, looking towards the future, as I said, we've just completed a few minor renovations in order to add about 150 square feet to accommodate 3 more MGISP-960s, which should go live either this afternoon or tomorrow. That'll give us a total of 6. So just on those 6 instruments, a capacity of about 12,000. We're waiting, as I said, for mid-November for our 2 MGI-7000s, which should help alleviate the pressure on the front end. We are also adding 3 more C-gene Starlet instruments to give us 6 of those, and 2 more biological safety cabinets, additional recruitment, as Christine mentioned, and try to work on IT solutions, connectivity, because not only do we have to receive the samples, we've got to report, and we've got to report to the government, the province, to the ordering clinician or clinic, as well as to the respective health unit where the patient lives. And then finally, we're in the process of trying to implement combination testing for COVID plus flu and RSV. Again, the weather is getting colder, and flu season is just around the corner. So this is the picture Stephen showed you earlier of what the 7000 looks like. Just with that, of course, as I mentioned before, we have multiple different tube types that are coming in with NP swabs. And so we sent 10 different tube types to MGI or BGI to see whether, in fact, the instrument could handle them. And so they sent back this little picture of the dimensions that was ideal, how a swab should be broken or scored, the length of where the score mark is. But ultimately, this picture just shows the 7 different manufacturers' transport tubes that the machine could handle without difficulty. On the other hand, of the 10 we sent, these 3 were no good. And so these, if we continue to receive them, will have to be handled, aliquoted, et cetera, at the front end manually. Some are too long, some the cap diameter is too small, some the cap is too weak, and the machine, the decapper actually crushes the cap. So finally, just in summary, I hope I've been able to show you that how policy testing guidelines will impact testing volumes, let alone disease activity out there, which of course, obviously, as more people get sick, more tests will need to be done. Expansion requires human resources. Equipment automation, I think there's no way one could do 17,000 or 20,000 samples in a day strictly manually. It's impossible, in my opinion. Reagents, including the plasticware. For many months, we were focused on extraction reagents, the magnetic beads, and so on. And then it became apparent that plasticware, the plates, the pipette tips, were also becoming somewhat scarce. Space is an issue, particularly as Christine mentioned, and you're trying to maintain social distancing in the lab and people aren't falling all over each other. And then finally, I think the ultimate is, which we're still struggling with, I believe, from a more broader provincial perspective, are IT solutions and connectivity in order to receive orders electronically and then send back results electronically anywhere within the province. With that, I will stop here, and I apologize, I believe we went over, but if there's time for questions, I think Christine and I are happy to take those.